going to talk about HIV in the ICU. I'm sure it'll be helpful even for Matt and Zoe. So HIV infection, there's an HIV virus. We know quite a lot about HIV. It has the glycoprotein on the outside, which allows it to attach to your host cell. And it's interesting that when I was a registrar, HIV didn't even have a name, and shows you how old I am. And it was only just being discovered. So going back in history, not quite ancient history, but in 1981, they first identified something funny was going on in the USA, mainly affecting MSMs who were getting unusual immunodeficiency type syndromes. So it was called acquired immune deficiency syndrome. Originally thought to be maybe a toxin related, but then a virus was discovered in 1984, which was initially called HTLV3, then HIV. And by 1985, a diagnostic blood test was available. By 1987, the first drug was licensed, AZT, but it didn't work very well. It only worked very temporarily, and then you got resistant to it. So any benefit only lasted a few months. And that was all we had really until 1996, when new drugs came along, and when you combined the drugs, that allowed you to then effectively treat HIV. So 1996 is the real watershed moment in HIV, when we were finally able to get the condition under control and people's immune systems would begin to reconstitute themselves. So before 1996, it was basically a death sentence, and you could ward off the final moments by treating the various opportunistic infections, but eventually everyone passed away. Since 1996, it's been a treatable condition, but of course not curable. All you can do is keep the virus under control. And by 2009, we'd combined all those therapies in one pill. So one pill once a day was the order of the day. And one of the next big advances, I suppose, was the idea of PrEP, pre-exposure prophylaxis. So you can give treatments before you're HIV infected, and that would prevent HIV infection. So if we look across the world, the latest figures from the WHO show that about 37.7 million people across the world with HIV, and still 1.5 million people catching it every year, and 680,000 dying. So although it should be a treatable disease, it's still got a very significant mortality associated with it. And looking at HIV a bit closer to home in the UK, it really peaked in the sort of mid-2000s, around about 2006. And the number of newly diagnosed cases has dropped quite significantly since then. The peak was over 7,000, now it's more like 4,000. This shows that probably the biggest reduction is in people with MSMs who've reduced their number of cases of HIV. So I might ask Matt, because he's the only one I can see, why do you think levels of HIV are going down in the UK?
Oh God, I should have left my camera off.
You can tell me who else is there, and I can pick on them. But
okay. I suppose I suppose PrEP is one thing.
Yeah.
But is it public health knowledge and that kind of sort of in the public domain a bit more and less taboo, perhaps?
Yeah, well, maybe less taboo. Public health knowledge was, we were aware of the routes of transmission even back in the 1980s. Everyone got a little pamphlet through their door, sort of with tombstone on it. But it didn't really make a lot of difference then. No, there's several reasons. One is, I think probably the most important reason, is antiretroviral treatment. So by treating someone, you reduce their virus count and make them less infectious. We're diagnosing people a lot earlier, and certainly HIV and GU clinics are testing people for HIV every time they walk through the door. And so people are getting diagnosed, and they're also presenting themselves for earlier diagnosis. Our peak of immigration from sub-Saharan Africa was the mid-2000s, so that's gone down. So that's probably one of the factors. And as you mentioned, pre-exposure prophylaxis. And one of the important things that we've realized in the last few years is that if you've got an undetectable virus in your blood, and the vast majority of our patients are undetectable, you can't actually transmit that virus. So you can have unprotected sexual contact and not transmit the virus. So there's a lot less transmission going on than there were before. So looking locally, HIV in Leicester, we've got around about 1,500, probably slightly more HIV positive patients. We used to have a monthly family clinic with about 30 children, and then it went to 3 monthly, and now it's just ad hoc. We only have about 3 HIV positive children, which is a good thing. The majority of our patients come from sub-Saharan Africa, and they're very nearly all on treatment, apart from a very small handful who won't take their treatment, who don't reluctant and refuse treatment. And of those on treatment, 95% are undetectable. So our figures are up there with the best, really. Our numbers increase by around about 1 a week, so about 50 cases a year. Some of those are newly diagnosed, and some of those are people that have come into Leicester from elsewhere. And we have around about 5 deaths per year, so not many people die. And the prevalence of HIV in Leicester is 3 per 1,000, which is towards the higher end nationally. There are places in London where it's between 5 and 10, but outside London, Leicester's got one of the highest prevalences of HIV. And just to refresh you on what happens if you catch HIV, well, the majority of people will get an acute seroconversion illness, which normally happens 2 or 3 weeks after you've acquired HIV, and is a glandular fever-like illness, but often not really spotted. Someone would just say it's a virus or upper respiratory tract infection or glandular fever and not test for HIV. And as you know, there's a long asymptomatic period of 8 to 10 years on average, although it varies quite a lot between people, where they feel entirely well. But they are infectious and can transmit that virus, but they don't have any symptoms. And then slowly, as your immune system declines, you develop various medical problems, HIV-related illnesses, and as your CD4 count goes down lower, you can then develop one of the AIDS-defining illnesses. And the natural history without treatment is that eventually you would die as a result of those opportunistic illnesses and death and malignancies. So if you look across the natural history, you can see that the virus initially, there's a big surge in virus. So you're actually most infectious about 2 weeks after you've been infected, before you develop any symptoms. Then your immune response begins to kick in and the virus level goes down, but not completely to zero. And then over time, your CD4 count will gradually decline and your virus will go up. So towards the latter stages of infection, again, you get very high virus levels and a low CD4 count. And the CD4 count really is a very good guide to the sort of problems that you're likely to get. Towards the early stages of infection, you can get some of these sort of immune-mediated diseases. Towards the sort of middle stage of infection, when your CD4 count is between 200 and 500, you can get annoying things like herpes zoster, bad herpes simplex, candida infection, seborrheic dermatitis, various skin rashes. So a variety of sort of non-specific conditions. And this is when HIV is often missed because you visit a number of different specialists and they don't think of HIV. And then in advanced HIV, when your CD4 count is less than 200, and as it goes down, then you get the major opportunistic infections that give you an AIDS diagnosis. And this is a list of all the AIDS-defining conditions. It's probably less significant now than it was 20, 30 years ago when there was no treatment. So AIDS was a sort of transition between being reasonably well and reaching a sort of more terminal stage of your illness. So an AIDS diagnosis was important, but less significant now, really. So what do we do with our HIV patients? Well, we monitor their CD4 count and their viral load. And a normal CD4 count is over 500, but really above 200, you're generally pretty well, because there's a little bit of extra in your immune system, so you can manage with 200 cells. But under 200 cells, you're at risk of opportunistic infections, and we would give things like Septrin prophylaxis for PCP. And if your CD4 count goes below 50, you're really quite severely immunocompromised, and anything can happen. And we've discovered over the last few years that it's best to treat HIV immediately. There's no benefit in waiting until your CD4 count goes down. So we treat them immediately, more or less the day they're diagnosed. And the very large study called the START study looked at immediate versus deferred treatment and found that immediate treatment gave you fewer side effects and fewer medical problems. And of course, it reduces transmission, so you get a double benefit from early treatment. And over the last 20, 30 years, the drug companies have been working very hard and developed a whole raft of different drugs. So we have nucleoside reverse transcriptase inhibitors, we have non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, fusion inhibitors, entry inhibitors. So 6 different classes of drugs that target different stages in the virus life cycle as it passes, penetrates the cell, fuses with the cell, gets into the cell, virus RNA turned into DNA, incorporated into your own DNA, translated into virus proteins, assembled into new viruses, and budding out the other side. So at each of these stages, we've now got drugs that will inhibit those stages. And you can see how many different drugs there are. So it's really become a fine art in deciding, which drug to give to which patient. And we will, we'll have our MDT and we'll argue the toss about should they have this combination or that combination, depending on that particular patient and their medical problems. But I guess it's better than having nothing. We've got, almost too many drugs now. And the majority of people will be on like 1 pill once a day. And that will be their entire HIV treatment, and we'll keep them alive and keep them well. So the benefits of treatment is within a few weeks, your viral load should go down to undetectable levels. Your CD4 count will gradually increase. It takes much longer. And if you've got a very low CD4 count, it might never go back to normal levels. Definitely reduces mortality and complications. People feel well on the treatment, and basically they feel back to normal. One of the problems with treatment is that often people put on a lot of weight and too much weight, which is a testament really to them feeling better and the drugs working well. And it reduces transmission. But there are problems. They do have adverse effects, less than they used to. The drugs are cleaner now. You have to take them. They won't work unless you take them regularly. You have to take probably 80–90% of your drugs to get an undetectable virus. And if you don't take all your drugs, you get viral resistance. And resistance can be a problem, means you have to change the treatment and often end up on a more complex regimen. So you might need 2 or 3 drugs a day rather than just the one combined tablet. Cost of HIV medication is not a major concern. It was a few years ago, but most of the drugs are now off patent and are generic. And so drugs that were costing £300 a month are now costing £20 a month. So really our drug budget has actually tumbled. It's gone much lower than it was before. So that's one small benefit there. So HIV in the ICU. 4 questions here I've got. One is, who do you test? So what might you do? You might decide that everyone in ICU should have a test. You might say, well, the one standard sort of planned surgery, their risk is going to be lower. So maybe just medical patients. Maybe we should try and stratify them and look at some with indicator conditions, or high-risk patients, people from sub-Saharan Africa, MSMs. Should we use an age criteria? I'll ask Zoe, because I asked Matt. Zoe, who What's your policy? Do you have a policy? How many tests do you tend to do?
I don't think we have a policy, and I think we should do it on probably more than we do. It usually gets, Felicia usually says, can we do it, rather than us having, but I think we should do it certainly on all medical patients. Maybe the surgical ones, it doesn't matter so much, but.
Yeah, I mean, I don't know the answer really. We have very low threshold for HIV testing. We aim to test everyone on the IDU. We don't achieve that, and there are patients that come through. But I suppose an elderly lady of 85 who has a fall at home, the risk of HIV is going to be pretty small in that sort of case. Whereas a younger person with bad pneumonia or sepsis, then they should be tested. Now, you may not be able to read this, but the British HIV Association has come up with guidelines for the type of conditions where you should think about HIV testing. So, and it depends what specialty. So like in dermatology, it could be herpes zoster. So a younger person with herpes zoster, seborrheic dermatitis, severe atypical psoriasis, mononucleosis-like illness, unexplained lymphadenopathy, unexplained oral candida, anal cancer, hepatitis B, C, A, unexplained chronic diarrhea, weight loss. Respiratory side, community-acquired pneumonia, invasive pneumococcal disease. So I guess really you're probably right. I think all medical patients in ITU should probably be tested for HIV. I know that the lawyers are using this as a way of trying to say that if you're not tested for HIV, that's potentially negligent practice. If someone presents very late and one of these conditions was missed and they didn't get tested earlier. So I think should be on the lookout, and like you say, probably testing more people than you are at the moment. So how do you test them? Well, it's a routine clinical test. So you have to inform the patient if they're aware and have capacity. So just like you're supposed to tell them about all the other tests you do. So my counselling for HIV would be along the lines of, we do a series of tests. You come in with, say, a pneumonia or TB. We do a series of tests, including an HIV test. And most people don't argue and are happy to let you go ahead and do that. So the less fuss you make about it, the better, really. You will have a lot of patients that aren't, don't have capacity because they're on various machines or they're confused. In that case, that you act in their best interest. And I don't know of anyone that's been sued for doing, an HIV test unnecessarily, because I think, if you think it may help your management, and clearly it's better to know they've got HIV, I would look at it as a test like checking the sugar level to see if someone's got diabetes. I mean, it's got the same kind of implications, that if it's not diagnosed and treated early, then the patient can suffer as a result. So there shouldn't be a big issue about testing for HIV. Who to admit? I mean admit to ITU, and that's crux of the matter really, and the reason I'm talking to you today, I suppose. That I think you'll probably see two types of patients referred to you. You'll see people who have the same conditions as everybody else in the community, who are on antiretroviral therapy with a well-preserved CD4 count, and they get knocked over by a bus, or they get pneumonia, or they have some other post-operative problem, and they behave basically like a non-HIV infected person. So if someone asks me about an HIV patient, the first question I'll ask them is what's their CD4 count. And if their CD4 count is 400 or 500, then they won't have an opportunistic infection. They'll just have the same things that anyone else would have. So they behave like a non-HIV infected. And occasionally you get drug-induced problems. One of the drugs we use a lot of is tenofovir. And when we first used it, we weren't aware that you could end up with renal tubular acidosis, which is, it can be very serious and life-threatening if it's not detected early. Now we do so many urine tests. Every time they come to clinic, we do a urine test, so we detect that early, and we haven't seen a case of that for a long time. But I remember we used to pretty regularly send people to ITU with very severe acidosis because of tenofovir, so that can happen. Majority of people that you will see referred to ITU are patients with more advanced HIV, CD4 count less than 200. And they'll really come into two categories. They'll come into the late presenters, i.e. those who've never been diagnosed before, and they turn up, you know, at death's door with a very low CD4 count, and we still see quite a number of those. Or there'll be people that we do know about that for one reason or another just don't take their treatment and allow their immune system to fall apart because they're not taking their treatment. So, and how do we manage them? Well, they're often quite complex and ill patients, and really you have to sort out their medical problems. And what we tend to find is that, you know, I'll do some case presentations later, is that they end up with a whole number of medical problems all at the same time. But, you know, I guess ITU are used to dealing with people that have a number of medical problems. That's what you're there for. And so you manage their various organ problems, their medical problems, provide as much supportive care as you can. And then the only specific thing about HIV is antiretroviral therapy. And the timing of antiretroviral therapy can often be discussed. If someone's got an opportunistic infection that's currently being treated, like PCP or HIV or cryptococcal pneumonia, it's not considered a good idea to then add antiretroviral therapy in the acute phase, because what you tend to get is a condition called IRIS, which is immune reconstitution inflammatory syndrome, where you sort of boost the immune system, and sometimes you end up with immune-mediated damage on top of the damage caused by your opportunistic infection. Little bit like, you know, some of your COVID cases seem to get better and then they suddenly get worse because their immune system goes into overdrive. So each condition, you have to weigh up the pros and cons of when you should start antiretroviral therapy. But that's something that ID physicians are pretty used to dealing with. So I think I'd be more than happy to discuss that decision with ITU. What about the outcome of HIV patients going to the ITU? Well, I looked this up, and I have to say there's not an awful lot of evidence. And certainly not very much from the UK, and not very recent either. So I'd love to say that, you know, there's great studies looking at hundreds of people with HIV. Probably the best one is a really quite an old study, 2007, by Mervyn Singer, you probably know, and Rob Miller. And they looked at their HIV patients. This was just soon after combination antiretroviral therapy. And they said the outcome of HIV-infected patients admitted to ITU was good, similar to that of general medical patients, and more than a quarter of their patients had newly diagnosed HIV in the ITU itself. So that study showed that it was probably beneficial to be in ITU, and they didn't do particularly badly. They did as well as medical patients with the same kind of problems. There was a recent review, also Rob Miller's on this one, management of HIV-infected patients in the intensive care unit. That's in intensive care medicine. And they pointed out really that there are mainly two types of admission: acute respiratory failure, and they pointed out that the IRIS might be significant there, bacterial pneumonia, PCP, and all the OIs, so opportunistic infections, CMV, toxoplasma, lots of pulmonary problems, PCP being the most common. And the other larger group would be those with neurological disorders, so that would be encephalitis or meningitis. again, quite a large differential diagnosis in HIV. And I think I'd agree with that most of the patients that we would send to ITU either have respiratory problems, majority I think have respiratory problems primarily, or neurological problems. It is a review, and it doesn't actually come up with too many conclusions, but the take-home message, they say, is that the majority of HIV-infected patients requiring ITU admission present with bacterial sepsis or exacerbated chronic diseases. Of course, HIV patients also have other chronic diseases as well. Severe AIDS-related opportunistic infections continue to occur in those with previously unknown seropositivity or limited access to drugs. Short-term survival has dramatically improved, certainly since 2006, owing to general advances in ITU practice and HIV care. I'd add to that as well. So
what was the rationale?
You can argue that with me if you like, but all the patients did okay at the end of the day for whatever reason, and two of them, one of them needed ITU and did well, and the other two escaped. I think the best outcome is not to go to ITU, of course. So my conclusions: HIV relatively common in Leicester, 3 in 1,000, so beware of that, and you know, always think about possibility of HIV and test as many people as you can, really. I don't think you can test too many. I really don't. I think, you know, the cost of the test is pennies, really, to do basic HIV antibody test. So do as many tests as you can. HIV is now completely treatable, compatible with normal life and normal life expectancy. So although patients may look pretty ill and pretty terminal when you assess them, you know, they do have the potential to get better and eventually lead a normal life after they've got over their acute events. And what we tend to find is that when you've got a very low CD4 count, you don't present with one thing, you present with 4 or 5 things, and you have to like juggle them all at once and get them all better. But they are rewarding patients to treat because you know, if you can get them through that effect, you can then manage them for years and years afterwards, and you can say, oh, you know, I remember when you were really ill, and look at you now, you know, you're a lot better. So, and ICU management, I guess, requires discussion and careful consideration. And usually, you know, you guys help us and we help you, and hopefully we have a good relationship. Occasionally, you know, we might disagree about patients, but I think on the whole, you know, we get good service from ITU. So I wouldn't be too hard. So that's my lot. Thank you very much. It's your turn to fire at me now.
Thank you.
What was the rationale for not taking the third patient?
Well, I don't know, and that's what happened after that was I wrote to I won't say who it was, one of the ITU consultants, and said, can you explain this? And it wasn't Zoe. They said, well, why don't you present at a meeting? So anyway. So I ended up presenting at this meeting. I'm happy to present at another meeting if you want me to. And it was discussed. I think it was discussed eventually. 6 different ITU consultants were in on the case, and they all agreed that they weren't going to take her. Now, I would have thought she's no iller than the second lady, and no iller than, I would have thought the first one had the worst prognosis, the man with the bad lungs, but he did okay and was taken. And she was only 32. So I don't know. It was COVID time. I think everyone's under stress. That may have made a difference. I don't know. Who knows?
It might have done. I don't remember the story, I have to say. So I missed it. But I think I'd be inclined, I'd probably treat you guys the same as I do the haematology guys. We bring patients with horrible stories of leukemia and stuff.
Yeah.
And actually they can get better very, very well. So I usually, if they say they should come to ITU, then I usually say yes. I'd do the same to you guys, I think.
You're too soft. We look
Maybe.
at haematologists and we think, oh, haematologists, you've got to be optimistic to be a haematologist.
Well, there is that.
and sometimes, they're trying to, hit someone with combination chemotherapy when they clearly, at the end stage of their disease. But
some of them have got are quite sensible. We've got quite a good relationship with some of them, so it's fine.
Yeah, but,
Paris, did you have a question?
And you may well say that physicians are unduly optimistic, and we want you to take our 85-year-old ladies who are frail, elderly, and when it's your patient, obviously you want to do your best for them, and sometimes the ITU consultant can just be the bring you back down to earth and be realistic, so a touch of realism. Sometimes we're just going through the motions. We ask for an opinion, not because we really think you're going to take the patient, but just that we've ticked all the boxes. And if the relatives, sometimes we're under pressure from relatives. I mean, all sorts of reasons why you might want an ITU review. And I suppose it's important that we discuss it with you. And if we say, well, look, we're under a lot of pressure here from the relatives, I don't really think that they're going to benefit from ITU. I just want you to confirm that. Then that puts a different complexion on the case. Whereas in this particular case, I was pretty keen for ITU to take the patient, because I thought she was tiring and I thought she was going to go off. But she was young enough that she managed to overcome her problems and get better. If she was being 62, she might not have made it, I suppose.
Yeah, the only thing I was going to say, sometimes we see patients in a snapshot. So at the time of review, if the patient was getting better or there's no one particular physiology that was off.
Yes. I think, a lot of medical patients are just off altogether, aren't they? I mean, they have a bit of this and a bit of that. And I guess what you people like is someone who's got pneumonia or something where they've got a single organ disease. You know what you're going to do. You're going to ventilate them, possibly maintain blood pressure, and that's it. And that's a nice, straightforward case. These HIV patients, they have so many different things wrong with them. It's difficult to kind of know where to start, really. So maybe, but yeah. But no harm in discussing these cases, is there? And it's always good to talk them through. And we miss things. Sometimes just a good second opinion. An ICU are good at making sure we've covered all the bases, really, and thought of everything. So thanks very much.
Matt, did you have something?
Yeah. And
I was just going to ask.
Yeah, of course.
I was just going to ask a general question. Do you think, obviously we've got reasonably good links with microbiology from an intensive care point of view, and we have regular ward rounds. I'm aware that in other countries there is quite a close integration between ID and intensive care. I don't know if you've got any thoughts on that, if you've ever experienced that in other centres, or how you think that might potentially work or benefit either or both of us.
Yeah, we're very much trying to blur the lines between microbiology and infectious diseases. And our training programme involves training in both disciplines. So even if you end up doing ID general medicine, you have to do a year of microbiology and take an exam which is 50% microbiology, 50% infectious diseases. So Leicester still, the departments are still separate. In quite a lot of hospitals, the departments are combined. So you could get an ID consultant doing a round one day, a micro consultant doing a round the next day. Traditionally, it is micro who do the rounds, but I don't know if someone like Dr. Vita turns up. He was one of our trainees, and he's now he's badged as microbiology, but he's also does infectious diseases. So I think it's good that you have an infection specialist involved. I'd like infectious diseases to be involved more, perhaps, but I think we're all infection specialists now. We should be able to combine our forces, really.
Brilliant.
We do have different flavour, I think. I think ID physicians are possibly more interested in diagnoses, in the other medical problems, and in management other than antibiotics. Microbiologists are probably more fixated on the antibiotics and the investigation of the infection. I mean, the patients, sometimes patients I saw PUO type patients, and you know, got to think more than just antibiotics, got to look for the source of infection or whether they've got another disease process going on. So I think we can complement each other, of course, but we have a slightly different outlook on the patients, perhaps.
Brilliant, thank you.
So for those of you who don't know me, my name is Paris. I'm one of the intensive care, anaesthetic and medical education fellows working in UHL, currently at Glenfield. Today I'm going to be presenting the paper for Journal Club, which is called FABLED, and this is how they got the acronym, which is weird, bizarre, but whatever, we'll go with it. So it's looking at the effect of antimicrobial administration on blood cultures and the positivity of the results after having the antimicrobials, and it's looking at patients in the emergency departments at A&E and who present with a manifestation of sepsis. So in this presentation, I'm going to go through what the question is, for what question they asked in order to do the study, a little bit about the background, some of the designs, some of the results. I'll talk about the strengths and weaknesses, and hopefully at the end we can have a discussion. So the question they asked was whether in patients with severe sepsis, what is the sensitivity of blood cultures taken after the initiation of antimicrobial therapy? And the reason why they asked this is because, one, in septic shock, we know that there is a linear increase in mortality for each hour delay in antimicrobials plus the other therapies that should be delivered. But we also know that inappropriate antibiotic use also results in an increased mortality. The surviving sepsis guidelines suggest that in the first hour we should do those things, and one of the things we notice is that the culture should be taken first and then antimicrobials administered. So there's a potential that if the cultures aren't taken and antimicrobials aren't administered, there could be a delay. So the question they asked was, what does it actually make a difference? Does the sensitivity reduce if you administer the antimicrobials? So what they did was, it's a single group diagnostic cohort study. So it's a prospective observational study across 7 EDs in USA and Canada. They basically saw if patients were within the inclusion criteria that they set, which I'll go through in a minute. They did blood cultures pre-antimicrobial therapy and post, and then they compared the results of the positivity of the results pre and post antibiotic therapy. So the inclusion criteria is what you can see on the screen, but essentially some of the things that I like to point out is the serum lactate and blood pressure. So the reason why they chose these markers was because these are associated with a high mortality and associated with septicemia. The current SIRS criteria used here is actually the older SIRS criteria, and which was the SIRS criteria when they first initiated the study, and they stuck with that. And I think midway through their study, which is across 3 or 4 years, the protocol or the SIRS criteria changed, and it's changed so many times but they stuck to the one that they started off with. And the way they excluded patients is obviously if they didn't, one, meet the inclusion criteria, but also if they had some severe coagulopathy in addition to their septicemia. And the reason for this is because they didn't want there to be any adverse effects from multiple venipunctures, which we've actually seen quite recently on ICU at Glenfield. So, I mean, the paper goes through all the patient characteristics that they had within the study protocol, and I've just picked out some of the ones that were sort of jumped out at me. One being the mean age being 66, majority being male. Quite a lot of them had a high lactate and low blood pressure. The primary infections were respiratory and genitourinary, but they did also include patients with gastrointestinal cellulitis and central nervous system infections as well. The initial antimicrobial regime differed between each of the different sites, so it depended on the protocols at each site. So, such as the ones that we have here may differ to the other trusts that we work in. The way they took the blood cultures is that once a patient was diagnosed with SIRS and with a possible infection, 2 sets of blood cultures were taken. Each from a separate venipuncture site, and each including an anaerobic and aerobic bottle. Then antibiotics were administered as part of the treatment, and a repeat blood culture was taken between 30 and 120 minutes from initiation of the antimicrobial therapy. Now, what they did was they actually calculated that in order to have a power of 90%, they need about 328 patients, and this is based on previous studies and the fact that there's about 35% positivity rate of blood cultures. But what they found is that they had to exclude a lot of patients because blood cultures were either taken too soon after antimicrobial administration, or they were taken after the 120-minute mark. So what they did was they actually had a second protocol, or they expanded the protocol to say that if they were taking up to 240 minutes, then they would include the extra patients to make up the numbers. So they actually changed their protocol slightly in order to get their numbers recruited. If the patients had the blood cultures taken within 30 minutes of antimicrobial administration, then they were not included in the study. What they looked at was the positivity of the blood cultures. So these are the results table, and basically the black box highlights the main results that they were looking at, the primary difference. So pre-antimicrobial therapy, they found that about a third of the patients had a positive blood culture result. And then post-antimicrobial therapy, this dropped down to about 20% or just under 20%. So there's a significant statistical difference in the absolute difference of the blood cultures positivity rate. But one of the things that was important to realize is that there's a couple of cases, or 3 or 4 cases, whereby the polymicrobial bacteremia results. So in the pre-antimicrobial blood culture results, and they said that if in those patients with polymicrobial blood culture results, in the post-antimicrobial blood cultures, if they didn't have the same bacteria, or if some of the results were negative, then that was counted as a discordant result. So that was counted as a negative result. But you could argue to say that actually, well, they still had a positive blood culture result. And the way they've done the analysis is that they analysed the patients according to the protocol that they originally set, which was to take blood cultures within the 30 to 120 minute mark. But then they also did an analysis on all the participants, i.e. those patients who had the blood cultures within the 240 minute mark. The secondary outcomes, which is quite obvious, is that if the patient had a positive blood culture result and they were then subsequently administered an antibiotic which happened to be effective against that bacteria, then they were less likely to have a positive result, which makes sense. And vice versa, again, if the bacteria was not sensitive to the antibiotic, then the blood culture positive post-antibiotic administration is more likely to be positive. What did they conclude from this? Well, they concluded that blood cultures post-antibiotic therapy significantly reduces blood culture sensitivity, and therefore makes it more difficult to administer a more targeted antimicrobial therapy for these patients, and therefore ultimately supports the sepsis, surviving sepsis guidelines. So the strengths of the paper were that they had good blood culture taking practice. So they took 2 separate venipuncture sites pre-antibiotic administration. It supports the surviving sepsis campaign. There's actually quite a low contamination rate amongst the blood cultures that were taken. And it actually answers the question that they've asked at the beginning of the paper. So some of the weaknesses I've managed to highlight are that there's no comparator, there's no compare group. It was just a single patient level study, so there's nothing to sort of compare it to, and therefore you can't tell whether there was a delay in administering the antibiotics as a result of attempting to get blood cultures, which could have an adverse effect on the patients, and particularly where 2 separate blood cultures were taken. Whereas I think currently where we practice is that we take 1 set of blood cultures and then we want to give the antibiotics as soon as possible thereafter. Whereas this talks about taking 2 separate blood cultures. So that could have delayed the administration of antibiotics and therefore had a more adverse outcome. But they haven't looked at that in this study. as I said, they required, according to their analysis, they required about 328 patients for 90% power. But for their actual protocol that they said, they only got 264 patients. And they actually just said that we'll expand the protocol in the minutes to include the numbers. So again, that sort of is a confounding factor. They actually screened over 3,000 patients, and 2,722 did not meet the eligibility criteria, and there was a further dropout because of consent and blood cultures not being taken and various other things. But out of those patients that did not meet their specific eligibility criteria, may actually still have had sepsis or septicemia, and including some or widening the inclusion criteria may have helped increase their numbers and got a more accurate result. So the other one was variability across sites regarding the methods of taking blood cultures and the antibiotic therapy administered as well. So, for instance, in a couple of sites, they on the second blood culture that they took pre-antibiotic delivery, they only took an aerobic sample, and in other sites, the amount of blood that they took was variable between different sites according to the recommendations of the laboratory at that specific site. Although the paper does talk about the fact that a minimum of 20 mils of blood was taken as per the recommendations in the National Antimicrobial Guidelines for the USA. So my conclusions are that it does actually reinforce the sepsis guidelines in that we should be taking blood cultures prior to administering antibiotics. Working at LRI, we do often see patients basically being showered with meropenem as they walk through the emergency department, and it's quite often difficult to ascertain whether they got their blood cultures pre or post antibiotic treatment. And quite often, from my experience, is that they haven't had the blood cultures taken, either because of the fact that the staff aren't trained to take them, and so they're waiting for a doctor to come and take the blood cultures and etc. And rather than waiting and causing a delay in administration of antibiotics, the antibiotics are just administered straight away. So I think we should be looking at expanding training for taking peripheral blood cultures. Having said that, the other thing I was also thinking was about ICU specific is that should we have a lower threshold for carrying out more septic screens? So I think our current practice on ICU is that we do, if we suspect sepsis, we do a full septic screen. So it's not just about taking blood cultures, we take all the cultures from the lines and sputum and so on. But whether we should be doing that on a more regular basis is something I discussed with Vas actually, that in some countries they practice taking regular septic screens, even if there's a little bit of deranged physiology on that day. So that's something we could potentially talk about and discuss today. But other than that, I think paper overall was as okay. It's good to see a paper that's not a big, massive randomized control trial, but still showed some sort of positive results. And yeah. That's it, really. Any questions?
Yeah.
Thanks, Paris.
So that was really good, Paris. It's quite an interesting paper. I think it's quite useful. But did they make any comment on the time from the antibiotics being given to when the second blood culture was taken, and whether there was any correlation between that duration and the chances of a culture being increasingly negative?
Yes, so the reason why they chose the 30-minute mark is because on a previous study, their second cultures were taken well within 30 minutes, or quite often at the time of an infusion of an antibiotic. So that study particularly showed that the results were more positive. They did find that the greater the delay, the more likely the negative result overall, but they didn't do a proper sub-analysis of it, if that makes sense.
Mm-hmm. Okay. My other comment was about regular septic screening. I think in principle, it sounds like a good idea. The difficulty with it, of course, is that you may well end up doing screens on people who you wouldn't otherwise screen. And then when you get a positive result, what do you actually do with that result? Does it actually have the converse effect that it increases your use of antibiotics where there wasn't any need for it? And that'll then increase the selection pressure for multi-drug resistant organisms on the unit, etc. So I think it's a bit of a minefield. That
I'm sure the lab would appreciate all the extra septic screens that we'll be sending them as well. So,
Ros loves samples. The more samples, the better. But
yeah, Felicity says the same thing.
But surely when they're appropriate, rather than just sending them. It's the whole thing about, isn't it, sending a test and getting a result you don't expect, and then what do you do with that result? That's the worry. I don't know what other people think.
Yeah, I suppose in the patients that we're seeing at the moment, they're quite severely immunocompromised on the basis that we're giving them really high dose steroids, and to a certain extent, we're not seeing them in septic shock per se. We start seeing a few deranged bits here and there, and then whether we should then that should trigger. But I guess I'm talking about more immunocompromised patients rather than general ICU patients.
I think most of our patients have positive bugs floating about quite a lot of the time, to be honest. Most of them from surgery. But yeah. Anybody else have anything to add? Anybody from the Glenfield actually there?
Well, that's harsh. Anyone from the Royal there?
I told you they're not there. I've had that meeting really open too.
Thanks.
Are we done then?
I think so, yeah.
Oh, cool. So Paris has put the QR code for the feedback in the chat. Next week, it's Dr. Chris Hebbs talking about traumatic brain injury, I think. So hopefully there will be people from the Royal there next week.
And I think it's going to be followed by some radiology teaching by one of the radiology registrars. So no general club.
Yeah, rather than a general club, yeah. I think so. So that would be hopefully be really interesting.
Cool.
Thanks, Paris.
Thanks, everyone.
Thanks, everyone. Take care.